Hi everyone, I'm Dr. Gokul SR, aka the Bloody Physiologist. Today we'll be dealing with a very important topic in cardiovascular system known as cardiac cycle. We'll be discussing about cardiac cycle under these three main headings. The first one is the duration and components. The second is the phases of cardiac cycle including the Wiggers diagram, and the third one is the pressure volume loop, both normal as well as abnormal. So shall we start? Yes. So what exactly is the cardiac cycle? Now, cardiac cycle depicts all the events that come associated with a heartbeat. Now, in our school days, we have heard that the heart beats around 72 times per minute. We are accustomed to hearing that the normal heart rate is around 72 per minute. We know that all physiological parameters, they need to be expressed in a range, and the normal heart rate is 60 to 100. But for the time being, we'll deal with this particular number because that's going to be very important. So this means that in a span of 60 seconds, the heart beats 72 times, right? If so, what is the duration of one beat? The duration of one beat would be 60 by 72. That will work up to around 0.8 seconds. So the duration of one cardiac cycle is 0.8 seconds. So now you can say the formula for finding out the duration of cardiac cycle duration is equal to 60 by heart rate. So as the heart rate increases, the duration of cardiac cycle decreases. Now this cardiac cycle comprises of two main mechanical events, that is contraction as well as relaxation. The contraction is what we call as systole, the relaxation is what we call as diastole. And the heart actually has four chambers which are capable of doing systole and diastole. We have got the atria as well as ventricle. Now coming to atria, we have atrial systole and atrial diastole. Atrial systole has a duration of 0.1 second and atrial diastole has a duration of 0.7 seconds. So now you can see the atria spends much of its time relaxing and chilling rather than contracting. But when it comes to ventricle, the ventricular systole has a duration of 0.3 seconds and ventricular diastole has a duration of 0.5 seconds. Ventricle is the main chamber that is doing all the heavy lifting of the heart, and the ventricular systole has got a duration of 0.3 seconds and diastole a duration of 0.5 seconds. This totals out to a duration of 0.8 seconds. Now atrial systole actually comes coinciding with ventricular diastole. So that means when the atria contracts, the ventricle relaxes so that it can receive blood from the atria into the ventricle. Okay, so this is the normal duration of cardiac cycle. But this might not always be the same, because the heart rate can change depending on various circumstances. For example, when we exercise, the heart rate can increase. So let's say there is an increase in heart rate corresponding with the degree of exercise, and the cardiac cycle can go, the duration of cardiac cycle can go as low as 0.3 seconds, the total duration of cardiac cycle, where 0.12 seconds would be for ventricular systole and 0.18 seconds would be for ventricular diastole. But here you can see that whenever the heart rate increases, the reduction in cardiac cycle, it comes more at the cost of ventricular diastole, because here ventricular systole has reduced from 0.3 to 0.12, whereas diastole has decreased from 0.5 to 0.18, which is a much higher decrease. So it is the ventricular relaxation and filling up of blood that suffers when the heart rate increases. Now that we have learned about the duration and components of the cardiac cycle, we need to be looking at them in much more detail. So now we are going to learn about the different phases of cardiac cycle. Now when we are talking about the different phases, we are going to be doing it from the perspective of the ventricle. So the different phases, all of them are going to be described from the perspective of ventricle. So you have got ventricular systole, which has got a duration of 0.3 seconds, and ventricular diastole, which has got a duration of 0.5 seconds, totaling a cardiac cycle duration of 0.8 seconds. Now ventricular systole has got 3 phases, ventricular diastole has got 5 phases. So that should be easy to remember. A duration of 0.3 seconds and 3 phases. Diastole, a duration of 0.5 seconds and 5 phases. The first phase in ventricular systole is going to be isovolumic contraction, this one. So you have to imagine the story beginning from this point. meaning the ventricle is ready to contract. So we are going to talk about the beginning of systole. So the ventricle has already finished diastole, finished relaxation. It has received blood from the atria. It is filled to the brim with blood, and now it is ready to contract. So you have got the valves. This one is the semilunar valve on the left side, that is the aortic valve, and this one is the AV valves on the left, so that is the mitral valve. So both the valves are closed. The left AV valve as well as the left semilunar valves are closed. The ventricle is filled up with blood, and now it is ready to contract. How does it contract? The myocardium starts contraction, and this builds up tremendous amount of pressure inside the ventricle. But because the valves are closed, the volume does not change yet, which is why this particular phase is known as isovolemic contraction. So pressure increases, volume remains the same, hence the name isovolemic contraction. Now what happens? So from here onwards, you can think about them sequentially. Now that enough pressure has been built up inside the ventricle, all that remains is the opening of the semilunar valves, aortic valve in this case. So there is a built-up of pressure inside the ventricle, the aortic valves open, so there is a sudden gush of blood from the ventricle into the aorta. So the blood is being ejected forcefully and rapidly from the ventricle into the aorta, hence the name of this phase is rapid ejection phase. What is going to be the next phase? So after a while, the pressure difference between the aorta and the ventricle will drop, because there was a build-up of pressure. A maximal pressure was built up in isovolemic contraction, right? Now during rapid ejection, the ventricle is still contracting and the pressure is increasing even further, but some amount of that pressure is actually being transmitted into the aorta. But after a while, the pressure inside the aorta and ventricle, the difference is going to be less. So this will still cause ejection of blood into the aorta, but at a much slower pace, which is why this is known as the slow ejection phase. So isovolemic contraction, rapid ejection, and slow ejection. These are the three phases of ventricular systole. Now that enough amount of blood has been pushed into the ventricle, what will happen? The semilunar valves will close, the aortic valves are closed. There is some amount of blood which is being left out in the ventricle after systole. What happens next? The ventricle will now start relaxing. So from here onwards, the events are going to be exactly the opposite of what we discussed in systole. Now the ventricle has got some amount of blood, it has started relaxing, but the valves are still closed. So that means there is a reduction in pressure, but the volume remains fixed. Hence this is known as isovolemic relaxation. But one thing that you should remember here is, during all these phases, the atria is actually getting filled up with blood. So you can see that the atria is now filled to the brim with blood. It is ready to empty that blood into the ventricle. And the ventricle has also become receptive by relaxing and reducing the pressure inside it. So what follows is, as you might have correctly guessed, the opening of the AV valves. So when there is the opening of the AV valves, there is going to be a sudden inflow of blood from the atria into the ventricle. Hence this phase is known as rapid filling phase. What happens next? The atria will continue to empty blood into the ventricle, but after a while the speed of filling of ventricle will be less, so this is known as slow filling phase. Another name for slow filling phase is something known as diastasis. So rapid filling and slow filling, this contributes to almost 70 to 80% of ventricular filling, which is passive filling. But even after these two phases, there is going to be some amount of blood that is left back inside the atria. This also needs to be emptied into the ventricle via contraction of atria. So the phase is known as atrial systole, which will now eject some blood into the ventricle. So these are the 5 phases of ventricular diastole. You have got proctodiastole, isovolemic relaxation, rapid filling phase, slow filling phase, and atrial systole. 5 phases in ventricular diastole and 5 phases in ventricular systole. This make up the total cardiac cycle. Now that we have learned about the different phases of cardiac cycle, we are going to be looking at ways in which these changes can be plotted as a diagram or a curve. The first among them is something known as a Wiggers diagram, as you can see there. Looks like a pretty complicated graph, but it's actually very simple once you get the hang of it. So mainly, what is the Wiggers diagram? It's actually a curve which is plotted against time of different parameters that change during cardiac cycle. What do I mean by that? So cardiac cycle is basically a mechanical event that occurs. We are going to be focusing on the left side. So what are these mechanical changes? There are obviously changes in pressure and volume. pressure and volume in which all chambers? We are mainly talking about three cavities. One is the atria, which dumps blood into the ventricle, which ejects blood into the aorta. So mainly you have got atrial pressure, you have got ventricular pressure and aortic pressure. What about the volume changes? Volume do change in the atria and ventricle, but we are going to be focusing on the ventricle. So you have got a ventricular volume curve. We are also going to superimpose the electrical changes that occur during cardiac cycle, known as electrocardiogram. We are also going to be looking at the phonocardiogram, which are the valvular events that happen, the heart sounds mainly. Now, before we dive deep into each of these curves, I always advise my students to get the valvular events out of the way. So, which are the valves that we are going to be talking about? As I said, we are talking about the left side of the heart. So, you have got the mitral valve as well as the aortic valve. You are going to be looking at the opening and closing of the mitral valve as well as opening and closing of the aortic valve. So where does the mitral valve close and where does it open? Look at this picture here. As you can see, at the end of atrial systole, the mitral valve was open. Now this entire sequence of events start again after atrial systole, and at the beginning of isovolumic contraction you can see that the mitral valve is closed. So where does it close? At the beginning of isovolumic contraction, which is depicted here. Mitral valve closes at the beginning of isovolumic contraction. When does it open? Mitral valve regulates the flow of blood from the atria to the ventricle. So when the ventricle needs to be filled up with blood, it has to open. So when does that happen? Look here, in the rapid filling phase. In isovolumic relaxation, it was already closed, whereas in rapid filling phase, at the beginning, it has to be opened so that blood can fall into the ventricle. So the mitral valve opens at the end of isovolumic relaxation or the beginning of rapid inflow phase. Clear? What about the aortic valve? Look at the isovolumic contraction once again. It was remaining closed there, but for the blood to be ejected into the aorta, it has to remain open. So in the rapid ejection phase at the beginning, it is going to be open, which is exactly what is being said here. The aortic valve opens at the end of isovolumic contraction. And when does it close? It has to close before the beginning of isovolumic relaxation, right? You can see in protodiastole, the aortic valve has closed. In slow ejection, it was open, whereas in protodiastole, it has closed. So the aortic valve closes here at the beginning of isovolumic relaxation. So once you get these valvular events out of the way, it becomes much more easier. So the mitral valve closes at the beginning of isovolumic contraction. It opens at the end of isovolumic relaxation. Aortic valve opening and closing is just the opposite. Aortic valve opens at the end of isovolumic contraction and it closes at the beginning of isovolumic relaxation. Now can we think about the phonocardiogram? We basically have two heart sounds in normal individuals, S1 and S2. At least that is what we are used to being told. S1 corresponds to the closing of the AV valve. S2 corresponds to the closing of the semilunar valve. So where should S1 be present? At the closure of mitral valve. Where does it close? Here. So in the phonocardiogram, you can see a recording there of S1. What about S2? S2 happens because of the closure of the aortic valve. So S2 happens here. Now you can also see two other recordings here. One is S3, which is represented here, and the other one is something known as S4. So S3 and S4. Now S3 occurs when there is inflow of blood into the ventricle, causing the vibration of the ventricular valves. So when we are talking about the atria and this being the ventricle, when the blood from the atria falls into the ventricle, there is a slight vibration of the ventricular valve. That is what leads to S3. It can be seen normally in exercise as well as children. If so, where should S3 be present? When there is rapid filling of the ventricle. So rapid inflow, you have got S3, the third heart sound. So what about S4? S4 happens when the atria has to contract against a stiffened ventricle. So due to some diseases, the ventricle is stiff, and so the atria has to forcefully contract in order to fill the ventricle with blood. So as you can imagine, S4 is going to be a pathological sound. S3 is physiological, but S4 is pathological. So when should S4 be present? When the atria contracts, right? So S4 should technically happen during atrial systole, something like this. That would be where S4 is usually present. A very important question. When or which phase of the cardiac cycle does the various heart sounds occur? So now we have got the valvular events out of the way. We are going to be focusing on the other parameters. The next parameter that we are going to focus on is the ECG, which is pretty much straightforward, because if you remember this particular dictum that we usually throw around in the case of muscle, which is electrical events always come before mechanical events, meaning in order for a muscle to contract, it has to first depolarize. So whatever contraction that happens, that occurs only after depolarization, right? If so, we can literally tell where each of the ways of the ECG is going to lie in a Wiggers diagram. So in ECG, I got P wave, which depicts atrial depolarization, QRS, which depicts ventricular depolarization, and T wave, which depicts ventricular repolarization. So atrial depolarization, it should come before atrial systole. So as you can see, here is the P wave, which is lying before atrial systole. QRS has to happen before ventricular systole. So QRS is here, ventricular systole, this is actually the isovolumic contraction. So that happens before it. T wave, which represents ventricular repolarization, has to come before ventricular relaxation. So that is what happens here. Here is the T wave, and this is supposed to be the isovolumic relaxation. So PQRST, they actually come before the particular mechanical changes that's going to happen to the myocardium. So next we are going to be looking at the ventricular volume changes that occur during cardiac cycle. So the pink graph, which is depicted here, and the different phases are being depicted there. Okay. So shall we start with isovolumic contraction then? So as the name suggests, isovolumic contraction. So the ventricle has been filled up with blood. It has just finished diastole. It is ready to undergo systole. It is completely filled up with blood. The pressure is going to increase, but the volume is going to remain the same. So isovolumic contraction, what happens is the ventricular volume remains the same. So what is the volume that is present, volume of blood that is present inside the ventricle at the beginning of systole? That is here, or it can also be labeled as the end of diastole. This is known as the end diastolic volume. In this case, that comes to somewhere around 130 ml. Right? So the ventricle has started contraction, but the volume has not changed yet because it is a case of isovolumic contraction. Now what happens? The semilunar valves have opened. Blood is being injected out into the aorta. So now the blood volume is going to reduce fast. Rapid ejection phase. After a while, it is going to slow down, slow ejection phase, and the systole has ended here. So what is the amount of blood that is remaining in the ventricle after systole? That is the end systolic volume. So if you look at this diagram, initially there was this much amount of blood, right? But by the end of systole, there is only this much amount of blood. So this is end diastolic volume. This is end systolic volume. So what about the blood that was present earlier? What about that deficit that has been thrown into the aorta? That is basically what you know as the stroke volume. So stroke volume is end diastolic volume minus end systolic volume. In this graph, it is going to be this much. End systolic volume, according to this graph, is around 50 ml. So the stroke volume here is going to be 130 minus 50, which is going to be 80 ml. Now, when we are talking about these volumes, there is also one more parameter that you should keep in mind, something known as ejection fraction. Again, in physiology, every term speaks for itself. Ejection fraction means the fraction of blood out of the amount which was originally present that has been ejected into the aorta. So what was the amount of blood that was originally present? That was EDV. How much has been ejected into the aorta? That is stroke volume. So that basically gives you the ejection fraction. So in this case, that is somewhere around, so stroke volume is 80, EDV is around 130, that will come to around 60%. Okay. It can be 0.6 if you express it as a fraction, or 60%. 55 to 60% is a normal ejection fraction, a very important parameter that is usually checked during echo. Now, is there any way that you can find out the end systolic volume from the ejection fraction? So if 60% of blood is thrown out, that means 40% of blood is remaining inside the ventricle, right? So how can you get that? 0.6 is the fraction that has been thrown out. That means 0.4 is remaining. How did you get 0.4? You just subtracted the ejection fraction from 1. So 1 minus ejection fraction into the end diastolic volume will give you the remaining amount of blood that is present inside the ventricle after systole, which is basically the end systolic volume. Okay. So 1 minus ejection fraction into end diastolic volume will give you end systolic volume. So in this case, 1 minus ejection fraction would be 0.4 into 130, that will come to around 50 ml. Now what happens after this isovolumic relaxation? There is no change in volume, and then the AV valves open, there is rapid filling of blood, then there is slow filling of blood, and then what happens? There is the final push by the atrial systole, the atrial kick, that again fills the blood into the ventricle to make the volume go up till the end diastolic volume levels. This is the left ventricular volume change that occurs during cardiac cycle. Next, we are going to be looking at the pressure changes that occur during cardiac cycle. The first one is the ventricular pressure. Now, ventricular pressure is a very easy graph. The pressure is only going to increase when the ventricle is actively contracting. That means during isovolumic contraction, rapid ejection and slow ejection. Otherwise, for most times, the ventricular pressure is going to remain near zero. So coming to the ventricular pressure curve, which is the blue one, it starts from here. There is isovolumic contraction. The pressure rapidly shoots up, but the volume remains constant because it is isovolumic contraction. Then you have got rapid ejection phase. The pressure keeps on increasing. It reaches a peak value of near systolic levels. In this case, that is around 120 millimeters of mercury. And during slow ejection phase, the pressure gradually falls down. And then during isovolumic relaxation, there is a drastic reduction in the pressure. It reaches near zero levels by the end of isovolumic relaxation. It remains somewhat same during the rest of the cardiac cycle. During atrial systole, when the atria is contracting and pushing some extra amount of blood into the ventricle, there is a slight bump in the ventricular pressure curve, but it again soon goes back to zero levels. This is the ventricular pressure curve. Next, we will deal with the atrial pressure curve. Now, the atrial pressure curve is a bit tricky. Now, whenever we are talking about the atrial pressure curve, we have to tell about the JVP, the jugular venous pulses. And as you know, the JVP has got three distinct wave patterns. So you have got the A wave, the C wave, and the V wave. You also has got two descents. One is known as the X descent, the other one is known as the Y descent. Okay, three waves, two descents. Each of these letters, they stand for depicting the exact cause behind those waves. A wave stands for atrial systole. So when the atria is contracting, obviously there is going to be an increase in pressure inside the atria. C stands for cusps. Now this mechanism is a bit interesting. So when the ventricle is contracting against a closed AV valve, the increase in pressure inside the ventricle will push the cusp back into the atria. This will result in a small increase in atrial pressure known as the C wave. So as you can see here, when the ventricle is contracting, this will push the valve into the atria. So that bulge of the cusp into the atrial cavity will result in a momentary increase in the pressure inside the atria, resulting in the origin of C wave. What about the V wave? There is this tendency among students to name this as ventricular contraction, but that is completely wrong. V stands for venous filling. The atria collects the blood from the big veins, right? So when there is gradual buildup of venous blood inside the atria, this will result in a gradual increase in pressure. As you can see here, this is a much gradual increase. So the V wave in the atrial pressure curve corresponds to the venous filling of atria by blood. What about the two descents, the X descent and the Y descent? Now X descent happens because the cusp was already bulging into the ventricle. When the ventricle relaxes, the cusp is going to go to a downward position into the ventricle, right? So the atrial pressure will decrease. So that is the reason for the X descent. The bulged cusp going back into its normal position and going further down because of ventricular relaxation. That is the reason for the X descent. What about the Y descent? Y descent happens because once the atria gets filled up with blood during the venous filling phase, the AV valves open, the blood falls into the ventricle. So the pressure inside the atria is going to reduce. So that is the reason for Y descent. Now how does this look inside the cardiac cycle? So this is the isovolumic contraction. So this is basically atrial systole. So the wave that you see here, this is actually the A wave. Isovolumic contraction, rapid ejection, that is where there is drastic increase in pressure of the ventricle. So this is the C wave. And this is where there is venous filling of the atria. So this is actually the V wave. Okay. This will be the X descent, the falling off of the mitral valve into the ventricular cavity. And this is going to be the Y descent. That is, after the opening of the mitral valve, blood from the atria goes into the ventricle. So this is how atrial pressure curve looks in the Wiggers diagram. The next important pressure that we are going to be learning is the aortic pressure curve. Now straight away you can see that the aortic pressure curve here marked in red is inherently different from the ventricular pressure curve. What is the main difference? The aortic pressure curve never goes down to zero during ventricular diastole, whereas the ventricular pressure curve during diastole it is near zero levels. What is the reason? The reason lies in our blood pressure, which is in a normal individual 120 by 80. This 120 is the contribution of the ventricle, and as you can see here, the ventricular pressure curve does indeed go up to 120 mm of mercury. Whereas during diastole, the body has to make sure that the blood will keep on moving. So during diastole, the aorta should not have 0 mm of mercury pressure, it should actually have a higher value. How is this made possible? This is actually because of the muscular walls of the aorta, which will accommodate the blood that is coming from the ventricle, but after that, when the aortic valve closes and the ventricle relaxes, this muscular wall of the aorta contracts around that column of blood, resulting in diastolic PP that propels the blood forward in the circulation. This is why the aortic pressure shows a value of 80 millimeters of mercury even when the ventricle is in diastole. So let's look at the curve in detail. So during diastole, the value is around 80 millimeters of mercury. During isovolemic contraction, that means the blood pressure, the ventricular pressure has actually increased, but that is not yet translated into the aorta because the semilunar valves are still closed. You can see it here, right? But what happens during rapid ejection? The semilunar valves are open, so the pressure is now getting transmitted into the aorta. So now the aortic pressure curve actually follows the ventricular pressure curve, especially during rapid ejection. But what happens during slow ejection? During slow ejection, the ventricular contractile force has actually reduced. So now, for the first time, the ventricular pressure has fallen below the aortic pressure curve. The aortic pressure curve is still having that inertia from the rapid ejection phase. So for a moment, it overtakes the ventricular pressure curve, as you can see here. And then what happens? At the beginning of isovolemic relaxation, that is protodiastole, you have got closure of the aortic valve. So now there is a sudden closure of the aortic valve. The blood which was actually present here is having a higher pressure than the ventricular pressure curve according to our graph. There is a sudden reflux of blood from the aorta back into the ventricle, but because the valves are closed, there is going to be a local turbulence being set up. This added with the muscular contraction of the aortic wall will result in a sudden increase in aortic pressure known as the dicrotic notch or aortic incisura. And then what happens? The pressure is going to gradually reduce to diastolic levels throughout the rest of the cardiac cycle. And this actually repeats again and again during the rest of the cardiac cycles. Now that we have got the Wiggers diagram out of the way, let us look at another way of representing the cardiac cycle. Now this may come off as second, but this is one of the most important topics, especially from any PG perspective. What you see there on the screen is something known as a pressure volume loop. So as with any graphs, you should first familiarize yourself with the x-axis and y-axis. So on the x-axis, you have got the volume of the left ventricle, and on the y-axis, you have got the pressure of the left ventricle. Now, the first thing that we should do here is to identify the relevant phases that we have just learned using the Wiggers diagram. So just like in the case of Wiggers diagram, we are going to start with ventricular systole comprising of the 3 phases and then move on to ventricular diastole comprising of the 5 phases. Okay. So looking at this diagram, where do you think the start of ventricular contraction is? Now remember, at the start of ventricular systole, the ventricle is filled to the brim with blood, it is ready to contract. So you should be looking at the area on the curve which has got the maximum volume, which in this case is going to be here. So this is the point of end diastolic volume. So in this particular graph, it is around 120 ml. Now what is the next phase? Next phase is isovolemic contraction. And what happens in isovolemic contraction? The pressure increases, but the volume remains the same, isovolemic, right? So what happens here? The pressure now starts increasing tremendously, but while maintaining a constant volume. So this is isovolemic contraction. And by around here, the isovolemic contraction phase has ended. The aortic valve has opened, as you can see here. Blood is now rapidly ejected out from the ventricle into the aorta. So what happens to the volume? The volume will now decrease, meaning it will shift to the left. So now what happens is, the volume has decreased, but the ventricle is still contracting tremendously, right? So that is going to keep on increasing the pressure. So you can see the pressure here rises to a peak systolic value of around 120 millimeters of mercury. Then what happens? The next phase is the slow ejection phase. As I said earlier, the pressure difference between the ventricle and aorta has now come down. The pressure is slowly going to fall, but blood is still being ejected into the aorta. So volume is also going to come down. So this phase where the volume as well as the pressure comes down, that is known as the slow ejection phase. And here, the semilunar valves have finally closed. That is the protodiastole. And following protodiastole, now the ventricle is going to relax. Now, at the protodiastole area, that is after the end of slow ejection, that is the end of systole. So the curve coming from here till here, that is the systole. So the volume of the left ventricle at the end of, at the point here, that is actually known as the end systolic volume, which in this case is around 50 ml. So 120 was the end diastolic volume, 50 was the end systolic volume. So the stroke volume here, which is the difference between these two, comes to around 120 minus 50, that is around 70 ml. Now it is the beginning of relaxation. The first phase is protodiastole, as we have seen. The next is isovolumic relaxation. So the volume is again going to remain constant, but the pressure is going to fall, which is exactly what you see here. The volume remains constant at end systolic levels, and the pressure comes down drastically to near zero levels. Following that, you have got the rapid filling phase, where the mitral valve opens. The blood inside the atria is going to be entering into the ventricle. But in the initial phases, this is not going to result in much increase in pressure, so it's going to continue like that. Then you have got the slow filling phase. Again, there is going to be influx of blood from the atria into the ventricle through the open AV valves. And finally, the atria are going to contract, resulting in some more blood inflow into the ventricle, which is going to result in a slight increase in pressure here, right? And by this point, the ventricular diastole has also come to an end. So this particular area signifies ventricular systole. This particular area signifies ventricular diastole. This is the pressure volume loop. The area under this curve actually gives a work done by the heart in completing one cardiac cycle. Now that we have seen what a normal pressure volume loop looks like, we are going to move on to some abnormalities. Now mainly from a NEET PG perspective, you have got 4 abnormalities pertaining to the various valves. So you have 2 valves on the left part of the heart, which is the mitral valve as well as the aortic valve. There can be mitral stenosis, mitral regurgitation, and aortic stenosis and aortic regurgitation. Let's try to understand what exactly happens during these valvular abnormalities. So first, we will take a look at the stenotic lesions. So on the left, you have got mitral stenosis. On the right, you have got aortic stenosis. Now, whenever you have a pressure volume loop question of the ventricle, the first thing that you should be looking at is the isovolumic areas of the pressure volume loop. So here, the isovolumic areas correspond to this as well as this. So in these pictures, the white one represents the normal curve, the red one represents the abnormal curve. Let's take the example of mitral stenosis. Now here, you can see that the isovolumic areas are preserved. If so, it is likely to be a stenotic lesion. In regurgitation lesion, which we will see in a while, the isovolumic areas are going to be skewed. What is the next thing that you should be looking at? The next thing that you should be looking at is the end diastolic volume. Remember, this was the normal end diastolic volume, whereas in this case, the end diastolic volume is here. So now there is a evident reduction in the end diastolic volume in this case. Now let us see what exactly is the reason for this. So in mitral stenosis, what happens is the AV valve here is going to be stenosed, right? So the opening is going to narrow down considerably. So what happens? The amount of blood that now moves from the atria to the ventricle, that is going to be less. That means less preload, less volume of blood after diastole. Because the opening is narrow, the amount of blood that is reaching the ventricle is going to be less. So what will happen to the end diastolic volume? It is going to be less. If the end diastolic volume or preload is low, what happens? According to Frank-Starling's law, the ventricular muscle is going to contract less. So which is also evident in the reduced peak systolic pressure that is generated in this curve. So in mitral stenosis, you will have a reduced end diastolic volume, and systolic volume will be maintained. There is no much issue with that, but the end diastolic volume is going to be low, and the peak systolic pressure is also going to be less. Moving on to aortic stenosis. So in aortic stenosis, what happens is the aortic valve here is going to be stenosed. So now the opening here is very less. The ventricle will have to try very hard to push blood through that. So what will happen? The amount of blood that is being pushed from the ventricle to the aorta is going to be less. That means more amount of blood is going to be left inside the ventricle even after systole, which will result in an increased end systolic volume. That is exactly what you see here. This is the end systolic volume. The normal end systolic volume was here. The abnormal end systolic volume is here. So the end systolic volume has increased, and not just that, the ventricle is now having a double disadvantage, meaning more blood is now present here even after systole. That means by Frank-Starling's law, it is going to result in an increased force of contraction. But not just that, the ventricle has to push blood through a narrow opening. So it is going to have to work real hard for pushing the blood through the aortic opening. So that will result in a very high increase in the pressure that is generated. So the peak systolic pressure is much higher in case of an aortic stenosis compared to a normal curve. So these features actually categorize this pressure volume loop as a case of aortic stenosis. If this is the case with the stenotic lesions, let's have a look at the regurgitation lesion. So what you have here are the regurgitation lesions. You have got aortic regurgitation and mitral regurgitation. Straight away, what's the first difference that you note? Remember when I said every time you look, you get a pressure volume loop, you should be looking at the isovolumic areas. In stenotic lesions, the isovolumic areas of the graph, they are maintained. You can see here in aortic stenosis, there is no change in volume during isovolumic contraction and isovolumic relaxation. Whereas in the case of regurgitation lesion, look at the graph. In isovolumic contraction and relaxation, that particular straight line is missing. So there is a deformation of the isovolumic phases in the pressure volume loops of regurgitatory lesions. So this is the first sign towards this being a regurgitation lesion. Now let's look at the aortic regurgitation graph first. Right? So here you have got the aortic regurgitation. So in aortic regurgitation, you have got this valve, the aortic valve, which is not patent. So every time the ventricle relaxes, the aortic valve is supposed to prevent the backflow of blood from the aorta, but in this case that is not happening. Blood is actually reaching back into the ventricle during ventricular diastole. So what will this result in? During diastole, more blood will be ending up inside the ventricle. So what will happen to end diastolic volume? It will increase, which is what you see here. The end diastolic volume is somewhere around here, right? Now what happens when end diastolic volume increases? There is going to be more blood inside the ventricle at the end of diastole, more preload, so the ventricle will have to pump much harder to eject that blood. So what will happen to the pressure? The peak systolic pressure will be increasing, as is evident here. This was the normal peak systolic pressure. This is the aortic regurgitation peak systolic pressure. You can compare it with the aortic stenosis graph. In aortic stenosis, the ventricle will have to pump harder through a stenosed opening, so the pressure is going to be much higher there. In aortic regurgitation, it's not going to be that high, but it is still going to be higher than normal levels. Okay, fine. What about mitral regurgitation? Here also, let's first take a look at the isovolumic areas. As you can see, they are skewed, right? These are the normal isovolumic areas. Those are already deformed here. What happens in mitral regurgitation? In mitral regurgitation, every time the ventricle contracts, the AV valve, the mitral valve, is supposed to prevent the backflow of blood from the ventricle to the atria. This is not going to happen here. This valve is incompetent, so blood is going to end up inside the atria. But what happens as a result of this? That means this extra blood which is now present in the atria, they are going to find their way downstream, right? Sooner or later, they are going to end up inside the ventricle. That means what will happen to the end diastolic volume? That will increase, which is evident here. The end diastolic volume in mitral regurgitation has increased. Now, compared to aortic regurgitation, the next difference that you notice, there is a significant reduction in peak systolic pressure. Why is this so? Now, here what happens is, each time the ventricle is contracting, some amount of blood is going to end up inside the atria. That means the mitral valve is incompetent, it is going to let blood go up into the atria. This means it is very difficult to sustain increased pressure inside the ventricle because blood is leaking out into the atria. So this will result in a lower than normal peak systolic pressure in case of mitral regurgitation. So with that, we have completed the cardiac cycle, some of the important points. So this is actually a bird's eye view of the cardiac cycle class that we have discussed. right? So cardiac cycle, the duration and components on one side, the phases including the Wiggers diagram on the other side, as well as the pressure volume loop, both normal as well as abnormal on this side. I hope you found this class useful. Thank you.